Bismillahirrahmanirrahim. The quote of the day is today be thankful and think how rich you are. Your family is priceless. Your time is gold and your health is wealth. The topic of today's presentation is economic evaluation, its introduction, and two of its type cost minimization and cost effectiveness analysis under the supervision of Professor Dr. Saira Afzal. The learning outlines of today's presentation is Introduction to Economic Evaluation, Types of Economic Evaluation, detailed discussion of cost minimization and cost effectiveness analysis, recent advances, and at the end are the MCQs. By the end of this presentation, participants will be able to describe the rationale for conducting economic evaluation, different types of economic evaluation, methods used for conducting economic evaluation, identify the major considerations when implementing an economic evaluation, and its strengths and weakness of economic evaluation. Now, what is economic evaluation? Economic evaluation is the process of systematic identification, measurement, and evaluation of the inputs and outcomes of two alternative activities and the subsequent comparative analysis of these. Or it can be defined as economic evaluations involve the identification, measurement, and valuation, and then comparison of the costs that are inputs and benefits that are outcomes of two or more alternative treatments or activities. Now the introduction to the economic evaluation. Economic evaluation is a way to identify, measure, evaluate, and compare the costs and results of programs and policies. Economic evaluation is the comparative analysis of or evaluation of the two or more interventions in terms of their cost and consequence. It helps in the evaluation or assessment of different programs based on their input given and the results or outcomes generated. It is a powerful tool that can help users make the most of resources, decide between promising program options, and demonstrate the benefits of the program. Now, what are the principles of economics? Central to the discipline of economics are the concept of scarcity, choice, and opportunity cost. As resources are scarce, thus every time we choose to use them in one way, we give up the opportunity of using them in other ways, with the implication that priorities have to be set to guide the resources allocation. Economic evaluation can be seen as a framework to assist in the optimal allocation of our scarce healthcare resources in order to maximize the health of the society by analyzing the costs and benefits of alternative healthcare intervention. Economic evaluation methods should therefore be seen as decision aiding instrument, but not only the instrument to guide the allocation of scarce healthcare resources. Forces that enable us to use economic evaluation are the existence of finite resources or the scarce resources. Prior to an evaluation, one must always check the effectiveness of the program. There is no point in carrying out an ineffective program efficiently. Now, why do we need economic evaluation? Clinical trials measure healthcare outcomes to determine the efficacy or effectiveness of healthcare intervention. If resources are unlimited, this is the only information we require to decide which interventions to use. We simply choose the most effective option. However, because the resources are limited, we also need to know whether the intervention represents good value for money. In other words, is it cost effective? In economic evaluation, the costs and the consequences of alternative interventions or scenarios are compared to examine the best use of the scarce resources. Economic evaluation is one of the tools available to help choose wisely from a range of alternatives and implement efficient resources. The specific questions being addressed may be a comparison of the costs and benefits between treatment and prevention activities, or the comparison of the costs and benefits of a new intervention to some current therapeutic approach, a comparison of the costs and benefits between treatment and law enforcement activities. Now, the importance of economic evaluation. The main aim of health economics is to maximize the health of population given the limited resources available. It is now an accepted paradigm that in order to make well-informed decisions about the best use of health services, healthcare consumers and policymakers must have information of both the costs and benefits associated with these decisions. It is only by comparing the costs and benefits of alternative decisions or strategies within a systematic framework that such resources allocation decisions can be said to be well informed. Now the components of economic evaluation. Healthcare programs take inputs like labor, capital, etc. and transform them into outputs. Input measure is called cost and it is mandatory units. Outputs are called effects and expressed in natural units such as percentage, detection, or completion ratio. Broader measure for of effects relies on utilities. That is the estimates of the satisfaction of the core effects, and the output unit is called a quality adjusted life years. These utilities are mostly used in cost utility analysis. Output expressed in monetary units are the as the cost, in which case the consequences are now called the benefits. When inputs are given to any of the healthcare programs in the form of like buildings, staffs, drugs, training, etc., and then when intervention is carried out or when program is carried out, like surgery, drug therapy, physiotherapy, counseling, the outputs can be in the form of effectiveness or the quality of life, utility, or the monetary value, that is in the form of money. Now, what are the costs? Costs can be direct, indirect, and intangible costs. Direct costs are those that are directly associated with an intervention. For example, cost of the medicines on the equipments, cost for the payment of the wages of the workers, and transportation costs. Indirect costs are those which are associated with missed wages due to illness. And intangible costs are hard to uh, uh, get their value. For example, uh, how much a person suffer from pain, suffering, or grief. Key features of an economic evaluation. An economic evaluation is a comparison of the costs and outputs of healthcare interventions. As such, it provides a measurement of economic efficiency. It must have two essential features. First is both costs and outcomes must be analyzed, and more than one alternative strategy must be compared. It should be clear that economic evaluation is not simply a matter of measuring costs of interventions and then choosing the cheapest option. This is incorrect. We cannot measure cost effectiveness without some sort of comparison. The choice of comparator may be difficult because we want to choose the best alternative from the point of view of both costs and benefits. No methods of economic evaluation. If we plot a table between the comparison of the one or more alternatives and both the costs and outcomes of alternative assess, if both of these factors are present, then we have full economic evaluation. And if one or two of them, both of them are missing, then we have partial evaluation. Now, how to do economic evaluation? Their steps include defining the economic question and the perspective of the study, determining the treatments to be evaluated, choosing the study design, identifying, measuring, and valuing the cost of alternative treatments, identifying, measuring, and valuing the benefits of the alternative treatments, adjusting costs and benefits for a different timing, measuring the incremental costs and benefits, putting the costs and benefits together and analyzing the results, and testing the sensitivity of the results. No economic efficiency. We often talk about trying to make the most efficient use of our available resources. Achieving economic efficiency entails obtaining maximum benefit from our given resources. It has two forms, technical efficiency and allocative efficiency. So technical efficiency. Technical efficiency is the choice of how to provide healthcare to minimize input for a given output, while allocative efficiency is choice of what healthcare to provide maximum benefit subject to given resources. Technical efficiency produces a given level of output at a minimal cost. Uh, let's take an example of technical efficiency. If our objective is to reduce the accident and emergency waiting times, we would achieve this by employing more medical staff or by training nurse practitioners to assess and treat patients with specific complaints. The most technical efficient option will be that which reduces waiting times at the lowest cost. We are simply concerned with how we meet our specified objective, that is reducing waiting times. While the allocative efficiency, the programs compete for the allocation of scarce resources. The example included must be, should there be an expansion of surgery or rheumatology clinics or renal services? Now, types of economical evaluation. Economic evaluation has four major types. That is cost minimization and cost effectiveness that we will discuss today. And the others are cost utility and cost benefit analysis that will be discussed in the upcoming presentations. In in all the forms of the economic evaluations, the costs or the inputs are in monetary values that can be dollar or rupee or any other currency, while the consequences or the outputs uh, of cost minimization is identical in all respects. It is assumed that the outputs are same, while in cost effectiveness, different magnitude to common measures, for example, life years gained, blood pressure reduced, while in cost utility, The outcomes are single or multiple effects on not necessarily common, valued as utility, for example, quality adjusted life years. While in cost benefit analysis, the output is also in monetary value. No cost minimization analysis. If the outcomes of the alternative strategies are demonstrated to be equivalent, then analysis will consist of simply comparing costs and choosing the cheapest option. The fundamental assumptions underlying this method are the two options being compared have exactly the same effect, i.e., that have identical benefits. The quantity of an effect must be exactly the same for all treatments, but also the quality of an effect must be the same, and important alternatives have not been left out. Example included comparing the administration of same VEGF inhibitor, that is vasoactive endothelin growth factor inhibitor, with the same administration technique in the hospital outpatient setting versus that in the private office. Here the exact same intervention is performed in a different setting and cost is compared to a certain which is less expensive, and we will adopt that strategy which will be less expensive. Know the characters of the cost minimization analysis. In it, the inputs are in monetary values, while the output are in are none. They are assumed to be all the outcomes are assumed to be the same. Cost minimization analysis just measures the relative cost of an intervention, the assumption being that outcomes are equal. The strength of cost minimization analysis is it is the simplest of all forms of economic evaluation, and it is very useful method in evaluating the cost of a specific drug or intervention. Now the challenges. It can only be used to compare the products or interventions with equivalent outcomes or effects. In many real-life cases, two interventions may not always have equivalent outcomes. Cost minimization analysis is debated for its nature since only costs are measured. It is a partial economic analysis or it is a cost analysis. If outcomes are measured and found to be equivalent, it is cost effectiveness analysis. No cost effectiveness analysis. Cost effectiveness analysis is a way to examine both the cost and health outcomes of one or more interventions. It compares an intervention to another intervention by estimating how much it costs to gain a unit of health outcome, like a life year gain or a death prevented. This type of analysis is used to compare healthcare technologies that have different outcomes. Common one dimensional health benefits and which are measured in same units. The results are therefore helpful in determining technical efficiency. They tell us which strategy maximizes a given objective, such as improving pain score with lowest cost. No, the inputs as all the types of economic evaluation has in monetary values, while the outputs in cost effectiveness analysis are natural health units, that is a cost per unit effect. Examples including in case of cases, it can be cost per cases detected or prevented. In case of deaths, it can be cost per deaths avoided or years of life or disability adjusted life years. Characteristics are included outcome of two or more actions is unequal. Costs are also different. Cost per unit health outcome is calculated and compared. It allows comparisons among options with the same indicator of effectiveness. For two options, we can calculate that which one is most cost effective by the cost effectiveness ratio. If uh, one intervention has less cost effectiveness ratio than the other one, then we choose the that one that has least cost effectiveness ratio. No merits of cost effectiveness analysis. It helps in comparison of health outcomes for health decision makers. Interventions of same time competing for same resources can be compared. Demerits include only interventions that have outcomes in same measure unit can be compared. It is limited to a single dimension of effectiveness, so it cannot capture the multi-dimensional outcomes of most health promotion programs. And the number of assumptions are needed to complete the analysis. Collecting cost data not seen as key part of evaluation. Cost data is surprisingly hard to collect. Three types of comparisons become immensely easier with cost-effective analysis. That is the comparisons of different interventions for the same disease, comparison of different interventions for reaching specific segments of a population, or the comparison of different interventions for different diseases. Now, the procedure for cost-effective analysis includes establish goals to achieve that can be achieved by the projects, identify constraints on achieving goals such as budget capacity, and then identify all alternatives, then determine the interest rate, and then determine the life cycle cost of each alternative, and then use incremental analysis to choose the best alternative. This is the formula for cost effectiveness ratio. Now the cost effectiveness plane. If we plot a graph between the effectiveness on x-axis and cost on the y-axis, we can get the cost effectiveness plane, and it in the four coordinates we can assess that which intervention or program is best to uh, continue. For example, in quadrant A, when intervention is less effective and more costly, it is a wasted bay. We will not continue with this program. And in quadrant B, if the intervention is more effective and more costly, then it is in threshold bay. It is questionable whether to continue with this program or not. And in quadrant C, the intervention is less effective and less costly. It is also in threshold way and questionable. And in the quadrant D, the intervention is more effective and less costly. This is the best way. This is the dominant way, and we will continue with this program or intervention. Now this is the graphical representation that how the cost effectiveness will be calculated for different options available. This is an example of a cost effectiveness analysis. For example, we want to assess the cost effectiveness ratio of weight loss for different uh, types of programs. For example, diet program and medication. The diet program costs about $300 for 2 kg weight loss, while the medication costs $1,500 for 3 kg weight loss. If we calculate its cost effectiveness ratio, the diet program will provide less cost effectiveness ratio or like $150 per kg weight loss, while the cost effectiveness ratio for the medication will be higher, that is $500 per kg weight loss. So we will choose this program, that is diet program, as it is less cost effective. There is another example of cost effectiveness analysis, a randomized control trial comparing the cost in rupees and effects life save for 30 days of three thrombolytic agents for acute myocardial infarction. Cost effectiveness ratio in this case are the cost per life saved at 30 days. Now the cost and effectiveness of the three thrombolytic agents, that is thrombolytic agent A, B, and C. The cost of thrombolytic agents of A, B, and C are 1,510 and 300 rupees respectively, and life saved for 30 days are 5, 3, and 2 for the three thrombolytic agents. And if we calculate its cost effectiveness ratio, the cost effectiveness ratio are 200, 170, and 150 for all the three thrombolytic agents. So the cost effectiveness ratio of the thrombolytic agent C is least. So we will choose this thrombolytic agent C. Now the reliability of cost effectiveness analysis. Through the basic cost effectiveness calculation appears to be simple, but choices about units of measurement, definitions of interventions, scope of cost, and prices to be included, and it will alter the numerical results, but also will affect the interpretation of cost effectiveness ratio. In many cases, the difference is so large that the refining the underlying analysis is unnecessary. Now the limitations of cost effectiveness analysis. It does not inform whether or not to expand or scale up the program. It does not take into account the social desirability of health outcome, and it provides information about technical efficiency rather than allocative efficiency, and it cannot compare interventions with differing consequences or outcomes, and it cannot compare programs with different goals, and it compare disparate alternatives. It is narrow unidimensional measure of effect. Interventions often produce multiple outcomes. Now coming towards the recent advances. First article is vaccine storage and distribution between expanded program on immunization and medical store department in Tanzania, a cost minimization analysis. In 2016, the Tanzanian government shifted the vaccine supply chain responsibility from medical store department to the EPIs to reduce costs. However, cost estimates that informed the decision were based on invoice value of vaccines and related supplies rather than a proper economic evaluation study. Therefore, this study aims to compare the actual storage and distribution costs of vaccines and related supplies between medical store department to EPI. The method included in this study are micro costing approach was used to estimate a resource use at medical store department and EPI for the year 2018. Data were collected through a review of documents, warehouse databases, and interviews with key staff at medical store department and EPI, who included both capital and recurrent costs. The results of this study stated that the total vaccine storage and distribution costs were estimated to be 1,996,286 US dollars for medical store department and $543,648 US at EPS stores. The costs are for the storage, for transportation, and other costs included. The conclusion of this study is the storage and distribution of vaccine in Tanzania by the EPI reduced the vaccine supply chain cost to about 27% of the program cost at medical store department. Second article is repeated screening for syphilis in the third trimester of pregnancy, a cost effectiveness analysis. The objective of the study is to estimate the cost effectiveness of screening of all women during the first and third trimesters compared with screening just once during pregnancy. The methods of the study are a theoretical cohort of 3.9 million women in the United States to model syphilis screening approaches in pregnancy, particularly comparing one-time screening with repeat third trimester screening. Outcomes of syphilis infection included in model were congenital syphilis, intrauterine fetal demise, neonatal death, and total quality adjusted life years. Probabilities, utilities, and costs were obtained from the literature, and a cost effectiveness threshold was set at $100,000 per quality adjusted life year. The results demonstrated that repeat screening results in 41 fewer neonates with evidence of congenital syphilis, 73 fewer cases of intrauterine fetal demise, 27 fewer neonatal and infant deaths, in addition to a cost savings of $52 million and a 4,000 additional quality adjusted life years. The conclusion is using our baseline assumptions, our data support that in pregnancy, repeat screening for syphilis is superior to single screening during first trimester and is both cost effective and results in improvement in maternal and neonatal outcomes. So coming towards the MCQ session. First MCQ is when conducting an economic evaluation of a new health technology, which costs should be taken into account. First option is cost related to the use of technology, that is staff or supplies. Second option is costs associated with the adverse effects or complications that may arise due to application of the technology. C option is cost savings as a result of application of a new technology, or D option is cost and more costly and most effective technology. Which is the correct option?
D.
C is the correct options, as we will choose those programs that have that will be most cost effective. Second MCQ is two drugs can be used to lower the level of blood pressure. No other side effects or any other costs associated with the drugs. Drug A costs Pakistani rupees 2000 per month, while drug B costs Pakistani rupees 500 per month. Both the drugs lower the BP by the same value. Which one should be selected and why? Whether drug A because its cost is less than drug B because it is more effective than drug A. Either drug A or drug B can be used as they have same outputs. Drug B as it has more cost effective ratio than drug B. Option A is the right
D.
one. Option A is the right one. Because according to the cost minimization analysis, if the outcomes of the two interventions or drugs are the same, then we will choose that one that has the least cost, which have the less cost. Different treatment options are available for treating the fracture of femur. Which treatment option will be chosen for a careful data analysis of all the available options regarding their cost and effectiveness by the economical evaluation point of view? Treatment that is less costly and most effective, most costly and most effective, least costly and least effective, or most costly and least effective. A is the correct option. We will choose that one that has most least costly and most effective. You are assigned to initiate a breast screening program that have full economic evaluations. Economic evaluation programs are those that choose the best option. Take costs related to the use of health technology into account, compares two or more alternatives in terms of their costs and benefits, analyzes both the costs and benefits of health technology, or produces a valid result from decision making.
C.
B is the right one, as it compares two alternatives in terms of their costs and benefits. Fifth MCQ is a cost-effective analysis of for healthcare program in XY community estimate that the program A costs 10,000 Pakistani rupees, program B costs 3,000, C costs 60,000, and D costs 80,000. The effect produced in life saved are 50, 10, 40, and 20 for program A, B, C, and D. While the cost effective ratio is 200, 3,000, 1,500, and 4,000 for program A, B, and C. Which program is most cost effective, whether A, B, C, or D? Yes, A is the right option, as we will choose that program that will have least cost effectiveness ratio. An organization sets a goal to reduce the deaths related to tobacco smoking in a town XYZ by implementing either the treatment, law and enforcement, or education and awareness. When or how economic elevation help to choose a single program intervention from different options available. Whether given information about the most cheapest option has to select most effective program when resources are finite or when no alternative program available. C is the correct option, as we will do economic evaluation when our resources are scarce. Seventh MCQ, the public health team compared the cost of administration of the same COVID-19 vaccine with the same administration technique in the hospital outpatient setting versus that in a community outreach stations. They found that vaccination in hospital setting is less expensive and decided to establish vaccination center in hospital. This is an example of whether cost minimization, cost effectiveness, cost utility, or cost benefit analysis. A is the correct option, cost minimization analysis. 8th MCQ is cost effectiveness analysis. Economic evaluation method would be the best applied in which of the following cases? There are 4 cases. In first case, if we spend 3,000 Pakistani rupees to buy hemophilus vaccination and the outcome is avert infection or decreased by 1 case. Second case is spend 3,000 Pakistani rupees to avoid work leave by averting infection. Case 3 is
इसका होगा 3 C जब शायद याद नहीं आ रहा
A is the correct option, as in cost effectiveness analysis, the outcomes are in cost per unit case, so A is the correct option. Result from a cost effective analysis of a screening intervention program for preventing HIV/AIDS infections among 10,000 high risk women in ABC community showed what will be cost effectiveness ratio. The net cost of implementation, cost of testing and treatment, cost averted, cost of treating pelvic inflammatory disease, net cost including positive values minus money spent, and that is 10,000 100,000 Pakistan rupees, and the outcome is 10 pelvic inflammatory disease case reverted. What will the cost effectiveness ratio?
Tarifa?
C is the correct
C.
option. Yes, C is the correct option. If we divide cost from by the outcomes, we will get this value. 10th MCQ is different medical and non-medical options are available to maintain the blood glucose level in a normal range in type 2 diabetes mellitus. A researcher conducted a randomized controlled trial and found that spending 5,000 Pakistani rupees on a special diet and gym will reduce the blood glucose level to 100 mg per deciliter, while metformin costs 12,000 Pakistani rupee to reduce blood glucose level of 110 mg per deciliter. Which plan should be adopted if cost effectiveness analysis is adopted? Whether diet and exercise, taking metformin, or C option is not an appropriate method, cost utility analysis should be conducted. D option is not an appropriate method, cost benefit analysis should be adopted. Which is the correct option? If we calculate it by cost effectiveness ratio, as the cost of diet and exercise is 5,000 Pakistani rupees, while on metformin is 12,000 Pakistani rupees, and blood glucose level lowered by the diet and exercise is 100 mg per deciliter, and by metformin is 110 mg per deciliter. Cost effectiveness ratio of diet and exercise is 100, while that of metformin is 109. So we will choose that one that has the least cost effectiveness ratio. So the correct option will be A, diet and exercise. This is the key of the MCQs, and thank you very much.